Welcome back from the break, everyone, and thank you very much for joining our session. I'm delighted to be speaking on behalf of my colleague and friend, Maurizio Barreto, who's here from CDAX, which is the Centre for Data Integration and Knowledge for Health. And between Maurizio and I, we're going to talk you through our personal experience, perspectives, views on how we create better equity in global health, but particularly through the lens of health research and, of course, using data for better health research. So I'm going to talk first as briefly as I can, and then I'm going to pass to Maurizio. But what we want to have is lots and lots of questions from you, and have at least a third of our session over to fielding your questions. So I'll start us off, and then I'll pass to Maurizio. So there is huge inequity across the globe in where research happens, who benefits from the evidence that's generated in health research, and also where that research is led from. Over time, we've seen that there's been quite significant effort into changing where research capacity is being delivered, but this hasn't solved the problems whatsoever. And many of the efforts have happened around trying to change how research is led from each particular disease. So there's been really great strides in doing, say, HIV, malaria, TB research across the globe. But many of the efforts have been siloed around those diseases, or even a particular protocol, which is all great. And we've done very well in developing some quite advanced progress in those diseases. But what it hasn't done is particularly spread that capacity beyond that particular disease area. And I think we're also in this amazing situation now where health research methodology is changing really quickly. Whilst that's having great impact in some disease areas, perhaps maybe things like cancer or aging diseases where there's quite a lot of investment and interest, I also think there's a real risk in research in the global south getting left even further behind. So to me, data science presents a really remarkable opportunity to kind of change that inequity and really adjust what's happening. And so what we can think about is how research is changing from the old norms of really separated steps of surveillance, maybe disease characterization through to phase 1, 2, 3 trials. And we're moving into a much more fluid situation where there's much more integration between those steps and processes. And that is down to how research can happen more quickly and more things like agile protocols and different adaptive design approaches. But of course, in how we capture and analyze and generate findings from data. And so what I'm going to talk you through today is how we're approaching some of those opportunities and how we can maybe all work together better to ensure that research across the globe is really benefiting equally from these advances in data. So I think it's really helpful to think of health research as a whole ecosystem, and that data science obviously cuts across every single one of those, because whatever type of health research we're doing, we're generating data from those activities. So for any disease, we need to have a whole spectrum of health research happening. There's often a really strong focus on clinical trials. But actually, even to facilitate a clinical trial, we need to have good surveillance data. We need to understand the circumstance that trial is happening, and we need to be able to plan the studies with the right outcomes and to be measuring the right events in that population. But it goes beyond that. You know, we learned with COVID, and of course we've seen this with any of the other outbreaks, such as Ebola or even Zika. I think is one of my favourite examples, because we didn't even have any clinical trials in the Zika outbreak. So to tackle any disease that's been around for centuries, like malaria or tuberculosis, or new diseases as they come along with outbreaks, we need data from the whole ecosystem of health research. We need to characterize the disease. We need to measure what the burden is to the population. We need to understand the public health threats and how we can change behavior and perceptions in the communities to reduce transmission or lower incidence rates. And then we, of course, need to be able to look at what interventions might be possible to treat and prevent diseases and gather evidence on whether any interventions are actually working and are safe. And then, of course, how any of this evidence can be taken up into policy and practice. And so around all of these, we need to generate data, of course. And so thinking about how data science can be executed in the best possible way is a really exciting opportunity for improving how we generate new evidence in any of these steps. But there's good news in this, because actually it doesn't really matter what disease you're working on, or even what step in this research ecosystem. The component pieces of any research study don't actually differ very much wherever you're working in the globe and whatever disease you happen to be working on. And so what's a really convenient and helpful fact is that the steps and processes we need to teach and support happening across the globe are pretty much generic. We could do a really good job at addressing some of this inequity by better teaching people how to do those component steps. And so whether that's community engagement, how to design a study, how to turn your study into an operational protocol, obviously the data management steps, and then also pieces like turning your evidence into recommendations that can be taken up into policy and practice. We could do a really good job at sharing how that happens in different diseases, in different places, and across different organizations, and thereby everybody makes progress much faster. And so what we're trying to do is work across the globe to try and create an environment for that knowledge and capabilities to flow much better between different diseases and different organizations. So the Global Health Network was set up about 12 years ago in Africa, and that was around tackling that very first issue I explained about how we have this old-fashioned approach really to capacity building that used to exist around perhaps seen as teaching a group of researchers in any one place how to execute a protocol for a distant group, to collect data for somebody else that would go back to another organization. And the place where that research is happening wouldn't necessarily benefit. It might eventually benefit from the drug or vaccine that's being developed, but the team in place isn't really left with lasting capable skills so that they can run their own entire research portfolio. And so 10 or 12 years ago, there was some really nice beginnings of trying to think about how we can mobilize knowledge across different groups. And particularly in Africa, we were working to set up mechanisms to share how research was happening across diseases like HIV, TB, and malaria, and try and connect places with quite strong research expertise with those with much lower. And so this all began by being a resource centre for groups wanting to do research who had really low experience up to that point. And it took off really well and just showed how much appetite there was for sharing expertise in research, but also how these component steps really played out, and that there could be much gained from setting up these really precise communities of practice that focus on these cross-cutting topics. So 12 years on, the Global Health Network has now become this really vast platform that is connecting up between different research teams and areas and organizations. And it has 60 component different communities of practice that focus on particular topics, perhaps community engagement, research ethics, data science, which I'm going to come back to in a moment. And also it works really well as a convening facility for groups who are working perhaps in a particular network, or they have a research topic that they're focusing on. And so groups use this overall concept of a community of practice to have their own focused knowledge hub within this, where they can work as a team. So that works really well for these big international networks where there's maybe 10 or 20 different research organizations working across the globe who need a working space to come together to share what they're doing and progress, and share SOPs or progress of the study. But they can also use that as an opportunity to connect even wiser with the global health research community and share their methodology and also their research outputs and how they did that research. And so this exists alongside the original aim of the Global Health Network, which was to offer resources for people to undertake their own research. So together, it's still this resource centre as a vast community of practice, and then these different component knowledge hubs. And so it's now used by many hundreds of thousands of researchers across the globe, and they come from backgrounds such as nursing, clinicians, pharmacists, data scientists, and policymakers, community health workers. And that means it's a facility that everybody can come together and really connect up and have that movement of knowledge between research organizations, research teams, and also trying to make sure that we've got that access and equity to knowledge, which means the ultimate goal could be that you have a researcher in somewhere such as Nepal or in Peru who can access the same information. Next slide, please. Sorry, I've done myself. So we have these collections of knowledge hubs that cover all sorts of topics, and that exists for different organizations such as Fiocruz in Brazil, right across to research networks in Africa, say, collecting up on something like birth outcome data or looking at malnutrition in children. And these exist alongside the resources that people want to access to guide them in their steps and processes. And I'm also going to focus right down on the data science piece in that, which is where we come together to try and increase the capacity and use of data science. This is also active in the Global South because we have a vast connection of coordinating centres and teams who can actually make this knowledge mobilisation really happen and run activities on the ground, such as data science clinics or workshops or supported learning sessions, which really helps take all that information that the component knowledge givers are trying to get disseminated across the globe. This exists as a federated flat structure, and I think this is a really important point. We hear a lot of discussion around team science, and this whole session is about equity to health research. My personal view on this is we need to move away from PIs and lead centres and create mechanisms for research funding to be spread in a much more flat and non-hierarchical structures. And so the Global Health Network is set up as a very flat, decentralised operation where we have completely equitable research centres across the Global South who act as hubs for this, and the funding can go directly to each in a fair way. And I do think that this is, I hope, a really good potential model that others could find and move away from the old norms of having a lead PI to having this much flatter structure. So just to finish off, we have a brand new knowledge hub on the Global Health Network, and this is where HDR Global comes in. And this is a really nice new community of practice, which is hoping to enable everyone who's working in data science to connect their excellence and enable access to all the tools and resources and examples of good practice across that whole ecosystem of data science. One of the mechanisms we're using for this are Pathfinder projects, and here we can track particular projects and work out where there's barriers and also enablers and formally capture those so others can share and they can use that in their studies. So just to finish off, it would be great to hear from anybody who would like to work with us, and this is a completely open community of practice trying to drive data science and create this equity that we want to strive to create. So I am now going to pass over to Mauricio, who can give us some really nice examples of excellence, which CDAX, I think, could share so much to teach the world about good data science. So over to you, Mauricio.
Okay, thank you. Okay, thank you very much, Trudy, to this presentation and the opportunity and the invitation of the organizers to be here in this meeting and to present you a bit of our experience on CDAX. CDAX is a center dedicated to work with large and the national database from Brazil. And to put this data, transform this data in knowledge, in scientific knowledge, and applicable to policymakers process. Then our big challenge is the transformation of routine or big data into knowledge. I think this is a common task of everyone that is working with this kind of data, with routine data. And it's sometimes very dirty, very complicated data that need to be processed in different ways to be transformed at the end in some rationale or type of knowledge, testing hypotheses, or make other uses of the potential that exists in such data. But to do that, you have a lot of challenges, different kind of challenges. That in the beginning is not so easy to understand the complexity of this. Is a very complex field. Because involve a different type of challenge that need different types of expertise. To solve the problems. In place. Then I think we Trude said, about the communities, the need to form national and international communities to share experiences, to make things, quicker and make it possible to transform, quickly the data that anyone have, or any country, any region, have transformed this in scientific knowledge. This is the example that I said. SIDAX, you are unit here in Salvador, Bahia, Brazil. Brazil is a large country with over 200 million inhabitants. Then is a large country, a large population, and they have a lot of data produced in the health system, and in other systems, not only the health system, as you see, but other systems, that can put together, through mechanism of access, governance of this data, linkage of this data, and the other process that make possible at the end to work as researchers, work and use this data. I think one important point in this process is to know the ecosystem of data. Each country have a different ecosystem of data. How historically the databases, the data that exists in the country is organized, is different. It's not equal at all. UK is different from Brazil. Brazil is different from South Africa, and then there is big difference that each group is a very national problem, because it's a lot linked to the history of the country, history of the health system, history of different other systems that exist, how people assemble data and keep this data safely, and for how long this data exists is also an important point to be evaluated. In SIDAX, one of the first tasks was to build a concept of this. This is the basic concept of SIDAX. Is what you call data platform of SIDAX. That you have 3 different levels. And you have in the axis, vertical axis, that is related to the ethics and the safety and privacy. This is an important point in any context. How you preserve this data, how you ethically use this data, how you safely use this data, and how preserve the privacy, of the individuals, that supply the data. There is a lot of different mechanisms. I don't have time to expand here, but to create things like safety rooms, to protect the data, to operate the data safely, have adequate computational results. This is a challenge, is to have not only hardware, but also softwares, accessible, if possible, free softwares, that can be used, and this new generation of softwares has made it possible to work with large set of data in a more quick and speed, the time that it processes this data, given amount of hardware that you have available. One other point is the legal framework. Now, any country, different country, have a legal systems that, and part of the legal system deal with data, with individuals, data protection, and the other topics relevant for these things. Brazil have a law. I think you have a general reference, that is the European General Data Protection Regulation. But Brazil, for example, have a internal legislation, a specific law on data protection that is a reference for us. And this law was very generous in terms of stimulate, to use the data for the health research. You see one of the article of this law that is dedicated, to say that you stimulate the use of data, for good health research. Another thing is how to link this data. Every system in every country, the data are in different silos. That you need in some moment. To connect this data. Then the connection of this data is one challenge also. For example, in CDAX, you develop a lot of different in-house algorithms to do linkage. You see here some example of that. But you go there, then with this data, it was possible to form, different set of data. You see here, health and social data, and you can organize one thing that you call 100 million Brazilian cohort. It's one of the assets that you have housed in CDAX, is this 100 million cohort that in fact now have 130 million people registered in this cohort. It's a completely virtual cohort, where a lot of different data are assembled, and a lot of research, extraction and research have been done for this cohort. A similar birth cohort was formed, in the same perspective, using the same idea. With this data, I can say you a few examples, how rich this data is. For example, a recent study published in the Lancet Global Health showing the difference in mortality in children for the overall population in Brazil, but separated by ethnic groups, And it's very clear that the indigenous people, for example, have a very high rate of mortality all over the studied years. The Black population, that is 45–50% of the Brazilian population, is higher than the white population. But this difference is a lot increased when you look for different kind of problems. For example, if you look for indigenous mothers, the difference for diarrhea is near 15 times higher, than the other population. For malnutrition, the indigenous have 30 times more, undernutrition die for undernutrition than the other population. Then you see the capacity that we use this data was possible to show things that people thought about, but there was no data, to demonstrate in a clear format, the existence of so high level of inequalities. You can go through, you can see here, some evaluation of the impact of programs, of social protection programs. I'm going through here, this Bolsa Família program, this is a cash transfer, where you see that there is a huge difference, impact on children that receive, for mother that receive the cash transfer. And when you look with our data, it's possible to see that the difference, is higher in some subgroups of the population. Black mothers, poor municipalities have a great benefit. You also could develop another instrument like a Brazilian Deprivation Index, that is a national index. You keep your international partnership, you try to make efforts to make things and exchange with different groups in the world. This is very important in this field of practice and science. You try to give some example. For example, you work with a group in Pakistan, where you develop your federate analysis, of data to test, common models of data use, to be replicable later in other conditions. You see here another example, with the COVID vaccine, you did a lot of evaluation of effectiveness in Brazil, and it was possible to work with colleagues from Scotland, and produce, papers and results, put data from Brazil and from Scotland. You have a lot of activities in public engagement. This is very central in any data user, because you use data from the society. Then you need to be accountable. Yeah, you need to justify the data use. Yeah, and public engagement activity has been each time more. Yeah, an effort. Yeah, to contact it, to have contact and links with the general population in Brazil. Yeah, to explain. Yeah, the results of what what you are doing, and why to use this data. Yeah, and to produce results, yeah, that must be all the time accountable for, yeah, and you have a strong justification to generate benefits to the society. And it's only to conclude, CDAX and your similar experience in different parts of the world have shown that data-centered and multidisciplinary health research with routine data, including multi-sector data linkage, must be a relevant component in global health strategy. It could be a key element in achieving the United Nations 2030 Sustainable Development Goals. Thank you very much.
Thanks, Mauricio. That was excellent and it's a really good overview of the amazing work you're doing in CDAX. And I think so much potential of some of the approaches you've used. Really good comments through that I'd just like to pick up. I presented in my talk about how we're really trying to shift to this flat funding structure and team science. And today you and I were challenged to talk about addressing inequity. And so it was great to see a couple of people picking up on that. In your experience, and if you had a sort of magic wand to sort of pick one thing, what would you do to try and address how we can shift this sort of huge experience in the north to lack of engagement in the south, and also work to address some of the direction that the funding goes, or just how it works in that inequity. So what would you do if you had a magic wand and lots of funding, I suppose?
Oh, this is a big problem. Now there is the fund system. Yeah, there is no easy task. It's not. I think it's a more, in my view, is a political discussion how things are distributed in the world. In the moment that you have 90% of the health research, yeah, the resources are in the north and very few in the south. Yeah, this is a very asymmetrical thing. Yeah, that keep a huge difference. Yeah. Then what I can say is that you need to use it as best as possible the money that you have. Yeah, I think that you need to have very well focused. Yeah, have a very clear priority. To use it. Yeah, in the best way. Yeah, the limited resources. Yeah, that you have. In general, in Brazil or other similar countries, now you have limited resources and you need to improve or to make all the best, yeah, to use as best as possible the resource available.
Great, and we've got some questions coming in now, so that's good. And just to update everybody, we're going to run through till we've got another 15 minutes. So we'll try and field as many questions as we can in 15 minutes. So so thank you. So there's a question here about whether your linked data, Mauricio, is all private data collected, or are you using government data too? And I think
is look, some systems are national. Yeah, there is no private thing. For example, a lot of the systems that the data that you use, if, for example, birth data, yeah, is national. Yeah, there is no public or private. Yeah, mortality data is national. There is no public or private. But when you go, for example, for hospitalization data, yes, you have private hospitalization. That is near 25%. You estimate to be in Brazil near 25%. Then you have this data you don't have. Yeah, you only have the 75%. Yeah, that came from the public system. Yeah. And then it related to the healthcare, yeah, you have this problem of private public, but related with public registers, yeah, you don't have this major difference. Yeah, there is no private or public.
I think that's really useful. And to me, I begun to work with colleagues in Brazil when we were working on Zika, and I really appreciated just a very different approach to research in Brazil than I'd seen anywhere else in the world, and that research seems to be much more embedded in healthcare delivery, and it's not such a different thing as it has been in other places of the world, where there's a huge effort now to try and embed. We talk about putting research systems in health systems, and we're doing a lot of work with the WHO on trying to link research and health. And I think, again, Brazil and the systems you have around using data sets. And that also links, there's a question in the chat from Alistair about how we balance this question of how do we get international collaboration to using routine data to scale. And it's back to this point about routine data or formalized clinical trial data. I think there's so much in that. And this is where the first point I made around, we've got these massive, huge accelerating transformations happening in how we can use data. And you referred briefly to federated analysis too. And I think this is a really significant opportunity and can be done in a more simple way than people often perceive. And so I'm going to push this back to you, because I think this is one of these really big concepts that actually could be broken down and made quite practical, that there's a lot of hesitancy and people get tied up around the concept of data sharing. But in fact, if we can do this more federated analysis and ask questions of data where it exists, that enables us to work internationally and have those collaborations, but also bridges that link between asking questions of maybe public health data sets or even formal, scientifically robust collected trial data. So just to push that back to you, how do you think we can accelerate our global learning or taking up these technical advances and better than we are now?
Yeah, I think this is an area that you need investments, yeah, but you also can use the intuition to do that. For example, in this experience in Scotland, yeah, you use there was two important things, yeah. One is that the data from a country from the south, yeah, and data from a country from the north, yeah, that have a very high quality data. Then for us was very important to show that our data also have quality, yeah, and you can do things together, yeah. But never the data from Scotland or the data from Brazil was out of Brazil or Scotland, yeah, stay here, yeah. What you use was the common, yeah, system of analysis, yeah. You develop the parameters of analysis, yeah, the program, all the analysis, and it was done with adapting to the data, to the structure of the data. This was done in Scotland and in Brazil in a similar way, yeah. Then this is very possible, yeah. What you have at the end was the tables and the graphs was put together, yeah. Because no data, there was no any flow of data, yeah, between countries. Another thing is to guarantee privacy, yeah. And for example, the data in CDAX stay inside CDAX, yeah, never go out from CDAX, yeah. But it's possible someone in other area from Brazil, or even in another country, for example, people in UK or United States have been using data from CDAX, yeah. But they don't, they are blocked from download any data, yeah. They only download, yeah, the tables and the analysis, yeah, the consequence of analysis. Then, and they work with disidentified data, yeah, but even with disidentified data, you keep the data internally, yeah, you don't flow the data in any way. Then this is in certain way guarantees that this can be, yeah, done, yeah, with some protection, yeah, and the following ethical rules, yeah, and legal rules, yeah. And another thing that is Sarah Khalidi that's talking in the morning, yeah, is an expert, yeah, have been developing a lot of mechanisms, yeah, of modeling of data common models of data, yeah, like Odyssey, for example, yeah, that it make it possible that you standardize better your data, that will make it easier, yeah, to harmonize and to do analysis in different parts of the world. Then I think this is necessary learning, is necessary development, yeah, and necessary to organize communities, yeah, to exchange experience, yeah, and to use the data, yeah, internationally, but respecting, yeah, the legal frameworks, yeah, the ethical limits, and a lot of different things, yeah, that is necessary to protect data. Then, but I think is possible, yeah, to do, yeah, federated or analysis, yeah, with colleagues from different parts of the world, yeah, and to collaborate, which is very efficient, in terms of generate quick results, yeah, like in vaccine effectiveness or in COVID studies, yeah, that you need to be quick in terms of producing results, and you need to use the data that is available, yeah, to produce these results. Then I think this make need a great effort of the scientific community, yeah, to work in this direction, yeah, and you also from bioethicists, legal teams, yeah, to solve, yeah, the computer people to create new instruments, yeah, of using and keep privacy when are using different types of data.
Thanks. I think you're exactly right. And just to pull out some of those strands, and it picks up a couple of the points we've made. So we've had a question around challenges of moving data between countries and some of the rules on that. And I think this is the point we're making, is that if we can create better tools for data harmonization, standardization, and some of the quality pieces, that somebody's also asked a question, so we can guide research teams on collecting data, or then building up the standards, working with data dictionaries and so on, and having these harmonized and standard systems, then it's possible to ask these same questions of data and do this, and that, so everybody does their analysis on their own data, and we can generate evidence across the globe. And I think this is such an exciting future for data science. And I think there's some really practical, achievable ways that we can implement some of those big blocks that need to happen in those areas to make that much more accessible. And I'll take that right back to a question that was asked earlier around cancer. And I think that's such a nice example that the point was made in the question that within a very few short years' time, 70% of the burden of disease from cancers is going to be in the global south and in LMICs. But currently, there's not much collaboration and hardly any engagement. I'm going to follow up on this with you, Mark, because I think that's something we need to change. But also, I think potentially oncology, and then some of the associated areas around that, pain management, diagnostics, all of those associated elements could really benefit from some of these having a really good set of shared standardization, quality, and systems where data can be analyzed in a harmonized way. We've just got a couple of minutes left, and I think it would be really nice to pass to Mauricio and just give maybe your overall summary of what I think we've said together, which sounds to me around working in a more global
I'd like to say that is a very important initiative to the Health Data Research UK to open the door to this international initiative. I think it's very, very important. And I think you need to mobilize all the resources. Yeah? For example, the WHO. Now, until now, I have seen WHO as a put the data problem is a big issue, yeah. Then I think you need to convince them that this is a big issue, yeah. For example, in the COVID pandemic, yeah, one of the big challenges, yeah, was a global problem, but you don't have a global capacity, not even to analyze the data. Nah? Then this is really a huge question to be put for this international organization, be OECD, be WHO, be others, the regional organization, like here in America, the Pan American Health Organization, yeah, that need to be aware that they need to really change and to have a more important role in this field, to corroborate, this idea and to make possible that in the future, to do international analysis and to research from different parts of the world to exchange data or to analyze data together can become an easy task than it is now.
Beautifully said.
Thank you.
No, beautifully said. Thank you. So I hope you've all enjoyed our session today. I think we've brought together some really important points. So we really appreciate HDR inviting us both. And I think we're passing over to Andrew now. Thank you very much.
Thank you. Bye-bye.